Welcome. This is number 2 in the series of greatest hits PowerPoint presentations that we have done in the past that have seemed to be of interest to a lot of our viewers. And hopefully this will be some help in understanding the scapula. This one is on the roles of the scapula in shoulder injury, shoulder function, and shoulder dysfunction. It plays a multiple types of roles, and we'll illustrate this by certain cases and discuss how these cases work out. So case number 1 is somebody that's very common, 45-year-old overhead worker. He has impingement with abduction and forward flexion. He has difficulty doing his work activities. He's had an injection, which gave him a little bit of relief, but no permanent relief. He has not had any relief by therapy, physical therapy, including modalities and strengthening exercises. So he was referred to see if he maybe needed some rotator cuff surgery or impingement or subacromial decompression. So his location of his pain is right on the anterior aspect of the shoulder where you expect it. He has a painful arc. It hurts as he goes into forward flexion. He has no loss of internal or external rotation, so it's not an adhesive capsulitis type problem. He just has pain right over the anterior aspect just below the biceps. He has demonstrated forward flexion weakness with pain with muscles testing. So like we should do, we should look at the patient from behind. And you see at the resting position of the scapula, there is an asymmetry with more prominence. You really notice this quite well as he brings his arm up and down. He gets this type 2 dyskinesis with his arm down as he lowers his arm. With upper trap activation, you can see the marked amount of upper trap activation. He has a type 3 dyskinesis as he brings his arm into abduction, with a type 1 on the way down as he's trying to control the eccentric load. Now we do these scapular assistance and scapular retraction maneuvers, and here we're doing the scapular assistance test. And once again, just assisting the inferior border, and we find that he can move his arm in farther abduction, and he gets relief of all of his pain of impingement. Then we do the scapular retraction test, stabilizing the scapula. Once again, testing his demonstrated flexion strength, finding that now he has no demonstrated weakness and no pain. So once again, you see the scapula plays a large role in these symptoms of impingement to the point where if you do the therapy, if you uncover these problems, they will probably not need surgery. The scapula plays a huge role in impingement. If you look at several studies have shown that if you do 3D kinematic analysis, that patients with impingement have statistically significant less posterior tilting, so that the scapula and the acromion cannot move out of the way as the arm goes into forward flexion. That's why the scapular assistance test works. So the pain is at the end, the victim, as we call, is anterior shoulder, but the culprit really is the acromial anterior tilt and protraction. Many studies have shown that kyphosis or protraction decreases the subacromial space, and protraction limits shoulder and scapular motion. The salty activation increases subacromial space if you increase strength of the serratus anterior and lower trapezius. There have been several studies that show, once again, that if you can increase forward flexion, demonstrated forward flexion strength, just by placing the scapula in the retracted position, you can actually improve their strength in injured shoulders 24%. All right, case 2. This is a 2A. This is a patient here. You see the MRI. He has a rotator cuff tear. This is a 2A would be an acute injury, a fall in the shoulder. 2B would be that you see this after 6 months to 8 months worth of chronic pain, and you have increased symptoms. So how does the scapula play a role in this demonstrated rotator cuff tear? Well, non-operative rehabilitation actually has been shown to correct scapular issues in the chronic tears as much as 80% decrease in the symptoms, and the request for surgery decreases by that same amount. These numbers, these outcomes are stable over 2 years as well. If you have large tears, you may need the Redding protocol. This is the Kaplan-Meier survival analysis curve shown by Dr. Kuhn et al., showing that at about 3 to 4 months, the curve levels out and it stays about the same level, about 80%, all the way out to 2 years. Do not seem to have much problem with the symptoms enough to warrant or request surgery. Also, this function score versus range of motion, whether you have scapular dyskinesis or don't, is a huge difference. If you do not have scapular thoracic dyskinesis, your function score versus range of motion is a higher slope and reaches a higher value than if you have scapular dyskinesis. In rats, they've done these very interesting studies where they have actually created a model of rotator cuff tendinopathy and also a model of scapular dyskinesis. And they found that dyskinesis actually creates the rotator cuff tendinopathy and also increases the effects of this overload-created tendinopathy. And their studies reveal that dyskinesis is a separate variable in rotator cuff symptoms. Similarly, in Japan, they looked at an older population with ultrasound to detect rotator cuff injury, and they also evaluated scapular posture. They found a significant correlation in this population between posture and the presence of scapular protraction and in the presence of rotator cuff injury. So let's talk about case 3, talk about throwers. This is a case of an overhead thrower, posterior shoulder pain, cocking to ball release. He has tightness of internal rotation. He has loss of total arc of motion, and he has symptoms of labral injury with a positive MDLS. So if you bring him into this position, you do the modified DLS test. He has a pain right in the posterior aspect of the shoulder, right where the internal impingement would be. Now, if you stabilize the scapula in retraction, moving the glenoid posteriorly, you do the exact same maneuver and you find that the pain is not there. You have eliminated the internal impingement mechanics. Now, you haven't fixed the injury, but that does show that there are a group of patients who, with a positive exam for labral injury, if you correct the scapular component of this, you can release the symptoms and actually get better function and less need for surgery. Why does this occur? Well, there have been several studies that show that some type of alteration of scapular position. In this situation, Dr. Yu did a test where he put 5 degrees of anterior scapular tilt onto a CT model of the labrum and rotator cuff, and he found that the increase in pressure due to this 5 degrees of anterior scapular tilt at the labrum and at the rotator cuff increased about 5 times over what would be normal. So showing that the alteration of scapular position motion had effect on the internal structures. Similarly, Dr. Mihata showed that decreased upward rotation increased the area of internal impingement on the labrum and rotator cuff. Increased internal rotation of the scapula increases not only the area but also the pressure, as we mentioned before. So this alteration of position and motion creates problems with increased area and pressure. Does this occur in athletes? Yes, it does. If we look at range of motion in scapular external rotation for elevation, you see that in the non-injured shoulder has higher amount of external rotation compared to the injured athlete at the position of 90 degrees of abduction. Similarly, scapular upward rotation, there's more upward rotation in the non-injured than in the injured. So very definitely, when you in the presence of these symptoms, you do have alteration of scapular position and motion, which need to be evaluated in the thrower. We did a study on this and looked at the clinical prediction of what are the factors for success or failure of non-operative treatment. It turns out that 54% of non-professional college, high school, recreational players with labral injuries do not need surgery if you put them on this 5 to 6 week program of addressing specific deficits. Now, if you have a painful arc of motion and real bad scapular protraction, those are predictive factors for failure of rehabilitation. However, 54% will not need surgery if you put them through this right program. So the SLAP injury by itself is not accurate enough to guide your treatment. Let's talk about support systems. Let's talk about clavicle injuries. So here's a case of a mid-shaft, slightly displaced, slightly angulated, certainly shortened rotator cuff injury in an 18-year-old soccer player 2 days after his fall. So what's going on here? How do we treat this? We say, well, you should treat it non-operatively or you should treat it operatively. Well, let's see if we can figure out why. one of the most interesting things is what are the deforming forces on that fracture? Turns out that there are a whole lot of forces creating anterior rotation of the distal clavicle and therefore its attached scapula. There's internal rotation of the shoulder. There's AC and CA ligament torque on the clavicle, CC ligament torque on the clavicle, gravity and arm weight, and muscle activations, all pulling the distal clavicle and the scapula into an internally rotated position. So you can't see that as well from the two-dimensional AP X-ray, but if you look carefully, you can see that that's the case as well. But certainly, if you look at the patient and you examine their scapula, you can see that on the left, here's a malunion of a angulated fracture that, like the one I showed. If you look at them posteriorly, you can see the effect of that rotated distal clavicle on the scapula as a type 1, type 2 dyskinesis, showing the alteration of mechanics that exists because of the loss of the strut. This is a plain X-ray and then a 3D CT showing the huge amount of anterior rotation as well as angulation, creating alteration of the scapula. On the plain X-ray, you can see that as well. Look at the glenoid on the right affected shoulder. It's almost facing your eyes. Compare the left side where the glenoid is where it ought to be, almost perpendicular. But you can see on the right side how the whole scapula has rotated so that the glenoid is facing the camera, which shows this anterior rotation and tilt. You see, once again, this angulation and rotation. All right, so let's take this case right here. This is another midshaft clavicle fracture, not as demonstrable as the first one. This is a 50-year-old cyclist, a very serious cyclist. He's one of these guys that do 100-mile bikes. 2 weeks after a fall, he was told he had no treatment necessary because he was out to length, but he has functional limitations and he came for a second opinion. And so, once again, if you look at the deforming forces, the same deforming forces are occurring here that occurred in the first case. And you can see this clinically. This is a video taken of this examination 2 weeks post-injury. You can see the bruising is still there. And you see that actually pressing on the clavicle, the clinical symptoms are minimal at the fracture site. He's got some callus. But if you look at his shoulder, it is drooped, it's protracted, and his impingement, he cannot get his arm even up to 90 degrees. He has pain along the lateral acromion. He has external impingement. If you turn him around, you can clearly see the asymmetry of the scapula with a scapular protraction of anterior tilt and internal rotation. Now, you can actually reduce this to a certain extent. You can take the distal fragment, you put the scapula back in the right position of retraction, stabilize him in this position, and now you notice he can raise his arm up to above 100 degrees without any problem. So once again, showing the effect of the scapular protraction on the function of the arm. And so when we asked him if he wanted to have his arm fixed, he said yes. So we went ahead and so the presence of scapular dyskinesis was an indication for surgical treatment. So here he is 3 weeks after surgery with a plate, and he's doing quite well. And you can see that he has the incision that's healing. His arm position is fine. Scapular position is normal. There's no protraction. And he can elevate his arm very nicely, showing the position and motion of the scapula has been restored by fixing the clavicle. So once again, one of the indications for surgery on the clavicle is the presence or absence of scapular dyskinesis as an indication that the mechanics of the joint are not working well. Well, let's look at another case. Here's a very similar thing. Here's an AC separation. So you see obviously the dislocation of the AC joint with the scapula being inferior, medial, and rotated in comparison to the clavicle. Well, what's the biomechanics? What's going on here? What's the treatment? Is this something you fix, something you let go? There's a lot of controversies about that. Once again, using the loss of the strut and the position of the scapula as an indication can help you. This is a 3D CT showing once again this internal rotation, inferior positioning of the acromion in relationship to the clavicle as the mechanical result of the injury. So what does that look like in the person? So here's a patient. He's a football player, 2 weeks after a fall with continued symptoms. And he comes in to get evaluated. And so you say, well, maybe this is a type 5, type 3, whatever it happens to be. Can you use this as a guide for treatment? Well, it turns out that by just moving the scapula, I can change this from a type 3 or a type 5 to a type 0. You can watch him here as he moves his scapula. He will reduce the AC joint just by moving the scapula. So just moving the scapula around alters this, showing once again that it's the scapular motion that can be a guide to the mechanical problem. And then you can decide whether or not you may want to fix that to stabilize this. And most of the time, if they have that real bad dyskinesis, then you can make a case for fixing it. This is another one. This is a very interesting guy right here. Now, this is a firefighter. He's 3 weeks post-fall. And what he has is a type 3, I guess you would say. You see the step off that exists. But if you turn him around, he has no scapular dyskinesis and he has full range of motion. So this guy does not need surgery because he does not have a loss of mechanics, even though he has the step off that you'd say, well, maybe it needs surgery. But if you look at the effect on mechanics of the scapula and arm, he doesn't need surgery. We put him on rehabilitation. He went back to work. And it's very interesting. He came back 11 years later because he fell on his other shoulder. But you can see that on the right side, 11 years later, he still has maintained his scapular motion and position. He has just a little bit of a step off, but he has no trouble. So once again, showing the durability. If he does not have that loss, if he doesn't have that loss of scapular control, then he can do very well. So here's another case. This is an arthroplasty case. He comes in 8 months after his reversed total shoulder with a painful, weak shoulder. And he said, well, maybe you need to have a revision of your total shoulder. And indeed, if you watch him, he can elevate his arm only so far. He can only bring us up to about 90 degrees, but he cannot raise it any higher. And you see the scapular motion is asymmetrical compared to the opposite side. And you do it a couple of times, you see how he loses control of the medial border. Now, if you do a scapular assistance test, my colleague Dr. Morris did this, and once again you can see that now he can move his arm into normal position. So his problem is not anything wrong with the reverse total shoulder, it's because of his alteration of muscle strength and scapular motion. Now, and the other thing, in addition, is that this is a setup for a stress fracture of the acromial spine, because he's still trying to raise his arm and he can't go any higher because the scapula won't go any higher. But if you get the scapula to move, then you take the pressure off the acromion as well. So look at that in those cases. This is a very interesting case, which is pretty rare in Kentucky, where we have a lot of horse people. This is a very interesting problem here, where they had a fracture of their scapula transverse below the spine. And usually these heal. However, this one did not heal. She got a non-union of this scapular fracture. And you see her clinical symptoms, she couldn't raise her arm. The clinical picture was exactly like a serratus anterior long thoracic nerve palsy, because she had a disconnect between the inferior border of her scapula and her acromion and clavicle. So they were moving separately. They could not work together. She could not elevate the arm, could not elevate the scapula. So therefore she was left with that position of only being able to raise her arm up 90 degrees. So this required open reduction, internal fixation, and bone grafting to stabilize this, to allow her to raise her arm. After that, she was able to get back on a horse and ride normally. So once again, you got to look at these scapular body fractures as a possible problem if it has this transverse type, for example. Finally, here's a case of a 16-year-old guy. He has a chronic going out of place, what we would call multi-directional instability. He has some pain along medial scapular border. His major finding is that he brings his arm into forward flexion and he goes up higher. Then he has the posterior subluxation and dislocation with asymmetry, as you see quite a bit of asymmetry of the scapula. Well, now you see the lateral tilt, inferior medial border loss, subluxation, going out and going back in. And it has to do with the positioning of the scapula. Now, if you stabilize the scapula, bring him up, now he does not sublux, because you have stabilized the border, so now the bottom doesn't drop out, and the glenoid stays in a position where now you have good concavity compression, showing that, once again, it's the scapular tilting, latissimus dorsi activation that creates the inferior tilt, which allows the instability to occur. It's really not instability because the translations are in the mid-range. Pain is the problem. Scapular motion is the key to understanding this, and it's a motion control issue. Hyperactive pectoralis minor, latissimus dorsi, hypoactive lower trap serratus and supraspinatus, giving that lateral tilt and then pulling out of place. So you need to evaluate the MDIs for scapular control, look at the medial border, look at the motion, look at dyskinesis, yes and no, do your corrective maneuvers, and check your low row strength. So this gives you an idea of some of the ways that the scapula plays into shoulder injuries and shoulder pathology, either creating the problem, exacerbating the problem, giving some indications for surgery so that you can be you have a better understanding of how this whole picture of the clinical dysfunction occurs. Thank you very much.